Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. If you've been following along, you know we've been diving into dermatologic topics geared for primary care. In this episode, we'll focus on basal cell carcinoma, the most common form of skin cancer. We'll cover the basics of what you need to know, from risk factors and clinical features to diagnosis and basic management strategies. Let's jump right in. First, let's talk about the basics of basal cell carcinoma. Basal cell carcinoma arises from the basal layer of the epidermis and its appendages. Unlike more aggressive skin cancers, most basal cell carcinoma remain localized. However, a few do become locally aggressive or, in rare cases, metastasize. Exposure to UV radiation from sunlight is the most important environmental cause of basal cell carcinoma, especially during childhood. This explains why basal cell carcinoma is more common in sun-exposed areas like the face and head. So who's most at risk? The primary risk factors for basal cell carcinoma are phenotypic traits, like fair-skinned individuals with light hair and eye color who sunburn easily, exposure to UV radiation from sunlight, and genetic predisposition. It's more common in older adults due to cumulative sun exposure, but the incidence of basal cell carcinoma among Americans younger than 40 appears to be increasing, particularly among females. Now, let's talk about how basal cell carcinoma presents. The classic lesion is nodular basal cell carcinoma, which presents as a firm, pearly papule with telangiectasias. These lesions are most commonly found on the face, ears, and neck. Other subtypes of basal cell carcinoma that are important to be familiar with include superficial, pigmented, and morpheaform. Superficial basal cell carcinoma presents as a scaly erythematous plaque that mimics actinic keratosis or squamous cell carcinoma in situ. Pigmented basal cell carcinomas are darkly pigmented lesions that can resemble melanoma, making them diagnostically challenging. And morpheaform basal cell carcinomas are ill-defined, scar-like lesions that are subtle but more aggressive. So basically, make sure you know that basal cell carcinoma can present in other ways, not just the firm pearly papule with telangiectasias. That's the classic description. Now remember, basal cell carcinoma grows slowly, so patients may describe the lesion as being present for months to years. They may also describe it as a non-healing lesion. And one last important note, sometimes the first symptom of a basal cell carcinoma can be bleeding with minimal trauma. Regarding diagnosis, the first step is recognizing the clinical features. Dermoscopy can be helpful, but any suspicious lesion should be biopsied. This not only provides pathologic confirmation of the diagnosis, but also provides information on the risk for tumor recurrence following treatment. The biopsy should be either shave, punch, or excisional and is usually done by a dermatologist. Now, let's talk about the management. The management depends on the size, location, and subtype of basal cell carcinoma. Generally, the first-line therapy for a surgical candidate with a low-risk basal cell carcinoma is with standard excision. And in cases of basal cell carcinoma with high-risk features, Mohs micrographic surgery is commonly performed. From a preventative standpoint, it's important to educate the patients about regular use of broad-spectrum sunscreen, protective clothing, and avoiding peak sun hours. In addition, regular follow-ups and skin checks will be necessary for any high-risk patients and any patients with history of basal cell carcinoma. Now, here are a few clinical pearls to take away. Number 1. Pearly papules with telangiectasias are classic, but don't forget about the subtypes like superficial, pigmented, or morpheaform basal cell carcinoma. Number 2. Chronic, non-healing, or bleeding lesions in sun-exposed areas are red flags. And number 3, always document sun protection counseling in your patient's chart. It's a critical part of care. All right, let's test ourselves with some clinical questions. Number 1, a 65-year-old man presents with a slowly growing lesion on his nose that has been present for 6 months. He describes it as occasionally bleeding but denies pain. He has a history of significant sun exposure as a landscaper. Physical exam reveals a pearly papule with telangiectasias. What is the next best step in management? Is it A, begin topical imiquimod, B, perform a shave biopsy, C, refer for Mohs micrographic surgery, or D, observe and reassess in 3 months? I'll give you a couple of seconds. If you chose B, perform a shave biopsy, you are correct. The lesion's clinical appearance is highly suspicious for basal cell carcinoma, and biopsy is essential to confirm the diagnosis before initiating treatment. Question 2. A 45-year-old woman presents with a pearly raised lesion on her neck that has been growing slowly over the past 8 months. She denies pain or pruritus but reports occasional bleeding after minor trauma. Biopsy confirms basal cell carcinoma. What is the best next step in management? Is it A, cryotherapy, B, topical imiquimod, C, standard excision, or D, radiation? If you chose C, standard excision, you are correct. Nodular basal cell carcinoma is typically treated with standard excision to ensure clear margins and complete removal. Great job! Thank you for joining me for this episode of the Pro PA podcast. Remember, recognizing and managing basal cell carcinoma early can make all the difference in patient outcomes. Don't forget to hit the subscribe button and turn on notifications so you never miss an episode. Stay tuned for our next episode where we'll tackle squamous cell carcinoma. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.